Started. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which we now gather. Just a reminder to please leave your questions till the end. We ask that you enter them in the chat. And please answer a brief survey that will be sent to you immediately after grand rounds today. This will let us know that you were present. And finally, our speaker today is courtesy of the Division of Geriatrics. And I'd like to invite the most recently appointed chair of the Division of Geriatrics, Dr. Doreen Wild-Showa, to present our speaker today. Thank you.
Thank you, Nadia. Good afternoon. Dr. Nathalie van der Velde is a consultant and full professor at the Geriatrics Department of the Amsterdam University Medical Center, the Netherlands. In 2022, she became a member of the academic board of the European Geriatric Medicine Society and subsequently has been appointed as academic director from 2024 to 2026. With regard to editorial tasks, she serves as Deputy Editor-in-Chief for Age and Aging since 2022. Dr. van der Velde is both nationally and internationally involved in research activities to improve falls and fracture prevention. She chaired the EuGMS Special Interest Group on Falls and Fractures, founded its Task and Finish Group on Fall Risk Increasing Drugs, and represents the EuGMS at the board of the Fragility Fracture Network. She's also executive board member of the World Falls Prevention Society, where she co-chairs the World Falls Guidelines Steering Committee. Welcome, Dr. van der Velde, to our MUHC Medical Grand Rounds, and thank you so much for joining us from the Netherlands. Thank you.
Thank you very much for that kind introduction and for the honorable invitation. I'm really happy that you're willing to listen to me and talk to me about my favorite hobby, which is falls prevention. I'll start sharing my screen. My title is actually my take-home message. Really try to remember a fall is usually not an accident. It's really important to start recognizing falls as medical symptoms. I have no conflicts of interest to disclose other than non-commercial funding for different ongoing studies on falls prevention. And of course, what was mentioned before, I'm co-chair of the World Falls Guidelines, so you'll hear lots of recommendations from those today. As you all know, our society is aging, and if we want to make sure that this silver wave will not become a grey tsunami, we really need to adapt our traditional way of looking at disease and having this symptom-focused approach to a much more functional and personalized approach. Because with age comes multimorbidity. When we look at those in the Western world of 65 years and older, about 50% has at least one chronic disease. And by the age of 75 years, this is already 3 or more. And this results in about 2/3 of those over 65 years having multiple chronic conditions. These multiple chronic conditions, this multimorbidity, results in polypharmacy, either appropriate but possibly also inappropriate, and functional limitations. And these are all reasons that a person may come to fall and injure himself. Falls are very frequent in older age, and they increase with aging. What we see is that about 1/3 of those 65 plus fall at least once a year, half falls more often, and this goes up by age. So by 70, it's 50%, and the 85 plus, it's already 60%. And these falls are not benign. About 50 to 70% of falls result in some form of injury, if we also count the bruises and other stuff. But if we're looking at serious injuries, these are also pretty prevalent. In those of 65 years and older, about 10% of falls will result in a presentation at the emergency department, and for 80 plus, that's already 14%. So what we see in all Western countries is that falls are becoming an increasing and really major healthcare challenge. With all these emergency department presentation, it is really the number one reason for injury-related emergency department visits in older persons. And in a more general sense, it leads to over 70 million disability-adjusted life years worldwide. And also we see the number of fall-related deaths going up steadily over the past decades. And this is about 40,000 per year in Europe alone at this point in time. And this also makes it a very costly problem. About 1 to even 1.5% of total healthcare expenditures are fall-related in different continents of the world. And this makes falls among the top 20 of most expensive healthcare costs for community dwellers. So we need to do something about it. And as I said, I will present some of the World Falls Guideline recommendations and elaborate a little bit around it with the current evidence. So starting at the beginning, identifying those at risk is, of course, essential. And in the World Falls Guidelines, one of the recommendations is that we should routinely ask about falls in our interactions with older adults. And this is grade 1A evidence. And the reason why we need to do this is because, well, it's effective to actually address it, but more importantly, people often don't present themselves with the problem of falls. So you need to actively ask them to find out that this problem is ongoing. And this is the top part of the fall risk stratification algorithm that we built with the 100 experts that were part of the World Falls Guidelines. And what you see on the left top is that opportunistic case finding I just talked about. And if we ask the question, the first question is, of course, did the person fall one or more times in the past 12 months? But you see two other questions, and these are the 3K questions, and these help to increase the predictive value of your risk stratification. And the second question is worry about falling, and the third is unsteadiness upon standing or walking. If it's a no, it's a low risk, which doesn't mean no risk. It does still mean that they need to get some general advice on exercise and safe behavior, but it's not high risk at the least. If it's a yes, or if the person presents to healthcare with a fall or a related injury, for example, at the emergency department, then the next activity is to assess fall severity. If any one of those 5 is positive, if there's injury, if there's multiple falls, if there's frailty, if there's inability to get up by themselves, or if there's loss of consciousness, suspected syncope, then it is high risk that we're talking about. If it's a no for these, then still we need to assess gait and balance by, for example, testing for gait speed. And if it's a yes, if it's lower than, for example, 0.8 meters per second, then there's an intermediate risk, which means we still give the general advices, but we also advise on falls preventive training like Otago, for example, exercise training. If it's a high risk, we need to do more. So what does the guideline say? We need to perform a multi-professional, multifactorial assessment to inform multi-domain interventions. And again, as I said, these are the high-risk groups, and this is what we need to do. We do the standardized multifactorial fall risk assessment, followed by individualized tailored intervention, and we need to make sure they're actually happening. So there needs to be a follow-up in the next couple of months. Why a multifactorial assessment? Really, falls should be seen as a symptom of an underlying condition that is possibly not revealed yet, and also because there's so many reasons why a person may fall. And more importantly, the majority of falls are multifactorial, and we know that fall risk increases with the number of risk factors. So you really need to go beyond the obvious and also look at things that are less in your face. Does it work? Well, this is a meta-analysis of all multifactorial falls preventive interventions that were at the time present in 2020 by Doutzenberg et al. And these were across all settings and all sorts of combinations of interventions. And what she showed that when we're putting this all together, we have a reduction in fall rate of about 23%. So yes, it is effective. We don't we can't get rid of all falls, but we can reduce them significantly. And every injury and every negative effect of falls we can arrange is very important for that individual. So if we're looking at that network meta-analysis, effective components of multi-domain interventions are exercise, which is really one of the basis interventions of any falls preventive intervention. And then comes the basic fall risk assessment and intervention, of course. And a major part of that is medication review, but for example, also a cardiovascular analysis. And I'll come back to that later. Environmental assessment is important, assistive technologies and quality improvement strategies. So this is not the only things you need to do, but these are the important things that emerge from that network meta-analysis. So if we're looking more closely into modifiable fall risk factors, the big group are the intrinsic fall risk factors. And well, I just said exercise is very important. So mobility is actually the number one fall risk factor, which is probably not surprising to you. And mobility, you need to address gait, you need to address muscle weakness, and you need to address balance. Then you need to look at underlying acute and chronic diseases, and I'll come back to that in the next slide. Functional ability is important, nutritional status, urinary incontinence, vitamin D deficiency, concerns about falling, pain, and vision and hearing. If we look closer into the underlying diseases, common fall-related diseases are osteoarthritis, dementia and depression, cardiovascular diseases, orthostatic hypotension, stroke, neuropathy, dizziness, Parkinson's and other neurological diseases, but also intercurrent diseases. And if we're looking at acute care, this is really an important one, because in acute care, we should really see falls as a red flag, especially in frail older adults, because it may be atypical disease presentation. You may be aware that older and frailer persons, and especially if they're also multimorbid, may present with more vague symptoms. Instead of coughing and having a fever when they have a pneumonia, they'll present with weakness and falls or maybe a delirium. So when they present in your acute setting, you should really be aware that maybe more is going on. And we saw a lot of that in the COVID era, where many older, frail persons with active infection of COVID presented with, for example, falls or delirium. And also cardiovascular disorders may be presented in this way, and I'll come back to that. So this is a figure that I would like to hand over for you as some food for thought. You may recognize the predisposing factors and the triggering events from the delirium guidance and delirium figures. And actually falls, it works in a similar way. So on the one hand, if we're looking at falls, you have the predisposing factors. And if there's many of them, or if they're really severe, like frailty, comorbidity, cognitive decline, mobility impairment, sensory impairment, if it is high, then only one little thing needs to trigger it. And then that fall may happen. So only a minor trigger is needed. If a person is really fit and doesn't have any problems, you probably need a major trigger to get people to fall. And the major trigger can be environmental, but it can also be acute events like infection, medication changes, side effects, cardiovascular events, alcohol use, etc., etc. So if we're looking into the depth of the World Falls Guidelines, it says that especially in that frailer population with a really high risk, we should see the multifactorial assessment really in a holistic way. It's in a holistic approach. It's our comprehensive geriatric assessment. And we need to look at, falls history, because it's the most important risk factor for falls, but also frequency, but then also look at the mechanisms of the fall. And your history taking is very important to find out what the possible underlying problems are, but also the consequences, the psychological effects need to be discussed. If you want it to work, and there's many studies showing that it's not about just giving advice. If we're doing pragmatic trials in the last few years, they weren't as effective. So it's really also about doing it together with your older adult, doing it together with your patients, so actually co-designing the intervention, tailor it to the individual, perform that shared decision making to really make sure the person will do it, but also that the advice fits the person. To come back to that acute setting, if they already present with a fall, for example, at the emergency department, you want to prevent that recurrent fall. And it's important to realize that you don't have much time, because the highest risk of that recurrent falls is in the first weeks and months. So you really need to act right away. And this is partly because of that atypical disease presentation that may be present, that underlying pneumonia or urinary tract infection or cardiovascular disease that wasn't diagnosed yet. And if we're looking at the emergency department, Dutch data show that indeed 90% of older adults presenting with a fall have one or more modifiable risk factors. So this really gives the opportunity for early risk assessment and treatment to prevent further injury, but also we know people get more dependent after falls with injury. So also we prevent functional decline and loss of quality of life that accompanies it. So just one more, because we're always busy at the emergency department, and it's, well, you feel you need to do something about the injury, but the rest should probably come later. But there's several reasons why it should also be addressed in acute care. So I just said the underlying conditions may be urgent, and the data really show this. If we're looking at older adults presenting at the emergency department, about 10 to 20% will fall again within the next 30 days. And if we're looking at that same group, we see that between 7 and 15% have a readmission in the emergency department with fall-related injury again in that first month or so. And if we're looking at long-term, a year, then it's already 40 to 50%. So it's really something we need to do something about and not wait too long. What we also know is that if we wait until the next fall, the time between falls will shorten. So there's less time every time you wait. And looking from it from an intervention point of view and from a patient point of view, it's important to realize that motivation for falls preventive interventions diminish over time. So people are very willing to do something about preventing falls and preventing injury shortly after presenting at the emergency department. But if you ask them to come over to the falls clinic or wherever you want to do their assessment in 2 or 3 months or so, they may not be interested anymore. And also, as I said in the beginning, usually they don't talk about falls so much because they think it's part of natural aging. And that ED visit may be the only contact they'll have with a healthcare worker because of falls. And that is your opportunity to actually intervene. Well, does it work to actually already act when you're in acute care? Well, we do know that it's actually the most effective case finding if you look at the effectiveness of fall risk falls preventive interventions. So we do know that in this group, multifactorial interventions lower the number of fall incidents by about 1/3. We also know there's not many studies, but there's some studies that look at actually doing something at the emergency department. And 2 examples that you see here, a physiotherapy consult and follow-up together with the medication review show a lower readmission of emergency department visits for any cost. It's halved. And if we're looking at readmissions for falls, then it's lowered by even 2/3. So it's really effective for preventing future injury, but also not directly related to another fall. But we need to be practical. So I really see the emergency department as a starting point of the care pathway. So you need to do your acute care. You need to make sure urgent and underlying conditions that can't wait are identified timely and addressed. But the whole assessment, looking at your mobility in a broad way, looking at your environmental factors, etc., can probably be done later on. So best is to have a transmural care pathway in place where after this, people are referred to, for example, falls services or maybe to primary care or your physiotherapies, depending on your local situation. What needs to be done at the emergency department is make sure those urgent problems aren't there. So these are the diagnostics we advise to do: short history taking and physical examination, an ECG, blood tests, a short medication review, I'll come back to that, urine testing, and probably an orthostatic hypotension measurement. And of course, anything that you see when you see your patients, you may extend on that, but this is sort of the basics. And examples of common interventions that you may perform in the emergency department to prevent future falls and injury is to deprescribe possibly temporary fall risk increasing drugs, to treat the underlying infection, to treat the orthostatic hypotension, to treat possible electrolyte disorders, heart failure or other cardiovascular diseases. But for example, also it could be the step up to further testing of transient loss of consciousness, because there may be syncope that is happening. Because cardiovascular falls are a very important thing to assess in acute care, and especially very likely if there's repeated and unexplained falls. Most common is orthostatic hypotension, but there's many other things. It's followed by vasovagal collapse, and of course vasovagal collapse is more well known for adolescents, but what we see is the prevalence of vasovagal collapse goes down. Well, after adolescence, it will be lowest around 40-50, but then the prevalence goes up again. So it may happen that the person used to faint when they were a kid, never fainted again, and then 70 or so, they start fainting again. So it's still something that could be newly diagnosed, so to say. Also, sinus carotid syndrome is frequent in older persons, and you may be aware what sinus carotid syndrome is, but this is sort of hypersensitivity of your baroreflex, whereby erroneously your blood pressure and heart rate is lowered because of pressure. For example, if you look up or if you're shaving, it thinks that the blood pressure is too high. Rhythm disorders may well be the problem, especially, of course, atrial fibrillation, but also other cardiovascular problems. So multifactorial falls assessment, and especially in acute care, should include that cardiovascular component. We should do the history taking, we should do the ECG, and we should do physical examination. And if we look at the numbers, the reason why is that syncope or pre-syncope are common. If we're looking at syncope, over 5% of falls are caused by syncope, but they may not always be recognized as syncope because half of the patients may not remember to have lost their consciousness. I'll come back to that. There we are. If we look at the different problems, this is underlying problems of syncope. This may differ a little bit. So, for example, in vasovagal syncope, it's about 40% that don't remember that they've actually lost consciousness. And in the carotid sinus syndrome, this is about 2/3 of persons. And this is important because, especially in older people, but also in younger people, there may be nobody there to witness the fall or syncope. And if it's non-witnessed, the person doesn't remember fainting or losing consciousness, and they find themselves lying on the floor and they will look for a reason. And they will see a carpet that's a little bit shoved to the side, or they'll see something on the pavement that they may have fallen over, and they will think that this is the reason they will fall. And this is what they will tell you: I tripped. So even if people present with a clear trip or slip, you should still be vigilant that possibly it can still be syncope. And the other thing is in older people, especially if there's other full risk factors, they may not actually lose consciousness, but if they get loss of oxygenation in the brain because of lower blood pressure, they may get dizzy and they may fall without actually reaching that point of time where they lose consciousness. But it then is a problem that needs to be addressed. So the cardiovascular causes of falls and syncope, I touched upon it. Orthostatic hypotension, blood pressure drops upon standing up is of course very common, and you probably know all about it. But don't forget about postprandial hypotension, hypotension after meals. This may occur up to 2 hours after the meal, and people you need proper history taking to find out that this may be the problem. And of course you can test it if you think this is problematic. Then there's the reflex syncope. We talked about the corroded sinus syndrome. We talked about vasovagal syncope, and then there's situational syncope, like in cases of pain or coughing or other situational triggers. And then there's the cardiac syncope, where it's rhythm and conduction disorders that may be the problem, or structural cardiac abnormalities, heart failure. And we all know, of course, about aortic stenosis as a potential reason for syncope, and thus also cardiovascular falls. But you should realize that practically all heart disorders may lead to falls or even syncope, because they may lead to temporary loss of cerebral perfusion due to either rhythm disorders or diminished cardiac output. And this is where I've put that down in a sort of schematic form. All these problems may lead either to temporary hypoperfusion on the top line, leading to syncope or near syncope. But another thing that is important to realize, that they may also lead to long-term problems if there's recurrent and significant loss of blood pressure and thus loss of brain perfusion. White matter lesions or even stroke may occur, and that may lead to cognitive problems, depression, or reduced mobility, and these are all full risk factors that may result in falls. And then together with the other full risk factors, such as vision problems, urinary incontinence, arthritis, or full risk increasing drugs that interact, that full risk increases even further. And that brings me to full risk increasing drugs. As you may be aware, with aging, the risk of adverse drug events go up by about 2 to 3 times. And this is strongest in polypharmacy. Actually, if we're looking at that acute presentation, 10 to 25% of hospital admission of older persons are directly caused by an adverse drug event. And actually, to be honest, often these are not recognized. For example, if it's fall-related injury. If we're looking at what are the most common and serious adverse drug events, then top one is gastrointestinal bleeding, but the second one in prevalence is fall-related injury. So it's really a common problem. So actually, fall risk increasing drugs are the biggest modifiable fall risk factor right after mobility problems. So it's major, it's modifiable, and it's common. If we're looking at older adults with a positive history of falls, we see that approximately 90% use at least one fall risk increasing drug, and many use more. So falls should really be seen as a major adverse drug event. And besides recognizing falls as a symptom, we should also realize that, especially in that acute presentation, but also in chronic presentation, it may be an adverse drug event that is not yet identified. So that's the reason why we should always perform at least a brief medication review in any setting if people present with falls. So coming back to the World Falls Guidelines recommendations, well, there's many on medication reviewing and deprescribing, but in this sense, a strong recommendation, grade 1B is that a medication review and appropriate deprescribing of fall risk increasing drugs should be part of the multi-domain falls preventive interventions. Because there's lots of evidence that deprescribing is effective as part of the multifactorial intervention, not as a single intervention, I must add that. And that makes sense because falls are multifactorial, and medication, effects of medication, both positive and negative, are interacting with underlying diseases, etc. It can be done safe, we know that too from the evidence, but in clinical practice, we tend to not do it or not do it so well because it's really a difficult thing to do, taking something away from somebody, and we're really, really afraid to harm people. In fact, what many studies have shown is that both patients and doctors, in a general sense, beyond falls, tend to overestimate the positive effects of medication and tend to underestimate the negative effects, the adverse drug event risk. So it's something that just feels unnatural, but we need to do it because it may be the right treatment for your individual person, but not with everybody because we want to keep the appropriate medication. So how do we do this? Another recommendation from the World Falls Guidelines: use a validated structured screening and assessment tool to identify fall risk increasing drugs when performing a medication review or a medication review targeted to falls prevention in older adults. With the European Task and Finish Group on Fall Risk Increasing Drugs that was just mentioned, and International Experts Group, we actually built several tools to support that. And this is the general tool for management of fall risk increasing drugs. And it starts by looking for the indication of that particular fall risk increasing drug, which may have never been there. Sometimes it happens, or it may have ceased to exist because people change. If not, then of course stop or stepwise withdrawal. If there is an indication, then the next step is to check for your safer alternative. If there is, then of course you change. If there's no safer alternative, the next step is to perform your shared decision making with your older adults and possibly other prescribing specialists to look into the most appropriate choice for that individual person. And you may decide to withdraw or to reduce dose. And when you do this, you're not ready because really it's a sort of continuous cycle where you have to monitor whether the symptoms that you deprescribed it in the first place for example, dizziness or orthostatic hypotension or delirium or vision problems or whatever, actually lessen or go away. And you have to make sure that there's no negative effects of stopping or reducing the drug. Possibly the symptoms it was described for in the first at first may return. But never forget your shared decision making because it's really the heart of what we need to do. Well, in general, I think in medicine, but for sure in medication reviews in older adults. Because it's not an easy thing to do, what we did with that Task and Finish group is design the Stop Fall tool, and this is published in Age and Aging, and there's also a digital version, which I will show later. And this is actually, it starts with a list of fall risk increasing drugs that the experts agree upon, and that are the most considered the most fall risk increasing. And it is followed by the steps that I just described to you, but then personalized for those individual drugs. So it will tell you which symptoms to follow up and in which cases diseases to consider deprescribing. But looking at the list and the groups of fall risk increasing drugs, the biggest groups and the most known groups are of course the psychotropic drugs, and the highest risk within that group are the benzodiazepines and the benzodiazepine related drugs. But also antipsychotics and antidepressants and antiepileptics may result in falls. And these falls may result from sedation, lower reaction times, these sort of things. But you should also be aware that there's many other adverse drug events also within psychotropics that may result in falls. And this may, for example, be rhythm disorders or orthostatic hypotension or electrolyte disorders. So it's really a broad range of things that may result in that fall. Then the next big group are the cardiovascular drugs. And the major culprits there are central antihypertensives, vasodilators used in cardiac disease, alpha blockers used as antihypertensives, and diuretics. Of course, many cardiovascular effects. There may be hypotension, rhythm problems, but possibly also, for example, electrolyte disorders or other non-vascular cardiovascular adverse drug events. And then there's the group of miscellaneous drugs, including the strong painkillers, the opioids, the antihistamines, especially the older ones, alpha blockers for prostate hyperplasia, urinary frequency and incontinence medication, and anticholinergics. And what that tool also gives you is that it tells you something about potential differences between classes, because maybe you do want to give that antidepressant, but not the most problematic one. So it will tell you which one are more full risk increasing than other ones if you're going through that. And for example, the example of diuretics, we know that loop diuretics are more full risk increasing than other diuretics. So that is a simple recommendation that is given within that tool. And the same goes for the antipsychotics. There's variation into sedative, anticholinergic, and alpha receptor properties. So that tool will tell you to deprescribe in which, to consider deprescribing in which diseases, in case of which symptoms, and how to do it actually, if you can just stop or should stepwise lower or do it otherwise, how to follow up, and which symptoms to monitor for. And this is the website that will take you to the digital version. And to be honest, we're just updating it with the expert group. So there will be a 2.0 version that is even more evolved. That will probably be there by the second half of this year. But for now, this is the old one that you can use. And I'm not sure if you use stop-start or beers mostly when you're doing your medication review, but the stop-start version 3 has the stop-fall tool included, at least the list of the drugs. To just talk a little bit more about how do we deprescribe, this is your dilemma. Many full risk increasing drugs treat full risk increasing diseases, for example, cardiovascular diseases. So we shouldn't just stop anything that has potential side effects. We should really look at the indication for the medication, make sure it's to address whether it's appropriate or inappropriate prescribing, and make that shared decision, do that shared decision making to find the safest drug in the safest dosage, and possibly, if we cannot do without, then make sure that there's injury prevention. But for example, there's other landmark papers that can be of help there. I said before that orthostatic hypotension is a very common problem in older adults and also a common risk factor for falls. And EuGMS had this really nice paper in Hypertension published showing the differences between orthostatic hypotension risk for the different drugs. And of course, you can look up the list, but if you want to change to a safer alternative, it's important to realize that the strongest association between orthostatic hypotension and cardiovascular drugs is found between drugs that affect sympathetic activity, such as alpha blockers, including urologics, beta blockers, tricyclic antidepressants, and antipsychotics. And a weaker effect is seen for those that are vasodilating. So, for example, the calcium antagonists, the ACE inhibitors, the ARBs, the SSRIs, the SGLT2 inhibitors. So you can really look into those differences. But sometimes you need to well, either it's not caused by drugs, but even if it's caused by a drug, you may not be able to deprescribe for obvious reasons. And then it's even more important to give proper education on what people can do. And I won't go through all the details of what to do if there's orthostatic hypotension. It's, of course, about fluid management. It's about salt. It's about exercise and alcohol and many things more. But what's interesting to see is the importance of contra maneuvers. What you can do with counter pressure, muscle counter pressure to raise your blood pressure. This is a really nice landmark paper by the group of Wheeling et al. In Lancet Neurology a couple of years ago that shows that if you do the right pressure, tensing your muscles in your legs and probably also your arms and buttocks, you can raise your blood pressure by about 50 millimeters of mercury. And that may make the difference between falling or fainting or being able to sit down or even keep on standing. Of course, the crossing the legs that you see on the left side, you may not want to do that with your frail older person, but there's many maneuvers that they can do, and especially the one on the right, most right, where they just pressure, put the knees together and press the buttocks and press the hands. It's very effective, and you can also do that sitting down. If you want to make all these advices work, we need to engage our older adults. I said that before. And to do so, a care plan needs to be developed to prevent falls and fall-related injury that incorporates goals, values, and preferences of the older adults. And again, that strong recommendation, 1B grade evidence. So it's really about joint management. It's about motivational interviewing partly, but it's about connecting, doing that shared decision-making. Make sure you know the goals, in life in a general sense, the values, that you talk about trade-off, that you talk about expected results, and that you evaluate the decision-making process. And this takes time, and sometimes it's difficult, but educating your older adult, your patients, and doing this shared decision-making together with them is so much more effective on the long run. That is not only good for quality of life, it's also really worth it from a cost effectiveness point of view. And this, of course, is very much true also for your environmental assessment, which is also a standard part of the multifactorial intervention. And everybody knows about rugs and lighting and all that sort of stuff. And in case of frailty, for example, an occupational therapist can do that assessment. But we should never forget other extrinsic factors such as alcohol. As with medication, with aging, the risk of adverse events or the risk of side problems because of use of alcohol increase strongly. And people may already experience problems with 1 or 2 glasses of wine. And in the older adults, there's a lot of usage of alcohol that is not recognized as problematic. It may not be problematic, but it may well have adverse effects that the persons themselves are not aware of. And of course, everybody knows that there's delayed reaction time and balance problems when you get drunk. And maybe they even realize that this is happening easier than it used to before, and they cannot handle as much drinks as they used to. But another one that's usually not well known is that alcohol also results in vasodilatation and orthostatic hypotension, and this may stay even the next day. And this is where your patient education is really important. Not everybody wants to minimize or stop alcohol, but if they don't know, they will not make that connection. And I have many people who were very happy that we talked about this and that they now know what to do about it. All right, to end with, I realize in a busy practice, you may not be able to do a full comprehensive geriatric assessment with the holistic approach to falls assessment, but a basic fall risk assessment should really always be done if there's a high fall risk. So that includes assessing mobility, looking at that gait speed, include concerns of falling, maybe do a short physical performance battery, and then refer to your physiotherapy. It includes a basic medication review. You can use stop fall and then maybe refer to your geriatrician, pharmacist, or other professional. Always perform an orthostatic hypotension measurement. Do that basic assessment of cardiovascular disease with medical history, cardiovascular complaints, and an EKG. Do a screening for underlying diseases, prompting questions that may lead to further assessment in case of memory problems or depression or whatever by a geriatrician or another medical specialist. Vision, again, prompting questions and then maybe refer to an optician. Nutrition, give general advice, check for sarcopenia and maybe refer to a dietitian. Give them information on how they can do an environmental check with a checklist, and possibly advise to go to an occupational therapist for a full assessment. Make sure they get their basic preventive education, and there's lots online available by now. And always consider referral to Falls Clinic for a full multifactorial full risk assessment. And that brings me to my take-home messages. Falls prevention should be performed at the point of care. Low risk is not no risk, so basic advices are there for everybody. In case of full risk, always perform a multifactorial assessment, looking at underlying multiple disorders, performing a medication review, be aware of that atypical disease presentation, and for effective falls preventive care, you need to perform that joint management and focus on patient goals. So thank you for that. We have time for questions, of course, and if you want to know more about falls, there is the World Falls Congress in Manchester in June. Thank you very much.
Wonderful presentation. Really, thank you for this comprehensive discussion or presentation on such an important topic that I think affects us all as healthcare professionals. So enter your questions in the chat and we'll take questions in the room. I see a question here. I recently tried to refer an elderly patient from family medicine to CLSC for gait and fall, wait time 1 year. Yes, so I think maybe I should preface by saying that we have not too much access to primary care in where we live in our province of Quebec. And so I think we need sort of, you presented to us a great presentation about point of care and emergency room. Maybe that question, because it's more of a local question. I don't know, Doreen or anyone from geriatrics has a comment about what we do here with respect to patients that we are concerned about in terms of fall clinic or fall prevention type clinic. Is there such a thing that we have locally?
Well, yes, Dr. Duque's falls and fracture prevention.
Okay, Dr. Duque, maybe you want to take the stage. Do you want to join the conversation?
Thank you. Thank you, Nathalie, for, how are you? I'm in charge here at the Division of Geriatrics, and thank you for this fantastic presentation. I think you did a fantastic job summarizing all this evidence. Regarding the question that was asked, our falls and fractures prevention clinic, which we have one at the MUHC and one at the Jewish General Hospital, we have established good links with the physiotherapists and with the CLSCs in the community. In some cases, for instance, for the falls and fractures clinic at the Montreal General Hospital, we have a physiotherapist on site. So part of the assessment for falls prevention is performed in cooperation and collaboration with the physiotherapist. And that facilitates also that the patients could be followed up in the community. So for those people who are interested on having this kind of assessments, our falls and fractures clinic is open for referrals, and the waiting time is not that long as 1 year. Definitely no.
Can you tell us
happy to know it's better, and good to see you, Gustavo.
Same here, Nathalie.
How to refer the patients, since you're on the topic?
Well, we have, I think that we have a contact phone and a contact. We have the, I don't know exactly the phone number, but I can share it in the
Maybe you
chat.
can enter it in the chat. Beware,
Yes.
though, you might get flooded. But yes, maybe you can let us know how to present these patients.
No problem of being flooded.
Okay, good. Ingrid, did you want to unmute yourself for your question? Ingrid Hings?
Yes, I just wanted to know how long, so is the comprehensive geriatric assessment like done by only the physician? Are there other team members involved? And how long does it take to do? Like, can it be done in all one shot? Does it require multiple visits? Who does it? Do family physicians generally do this? Or is this something more that the geriatrician does?
Well, if we're looking at falls prevention and the comprehensive geriatric assessment that we advise there, it is preferably done in a multidisciplinary way. And for example, the physiotherapist can do that part on the mobility and the well-advised exercise intervention. The occupational therapist may look at the environment. A pharmacist or another specialist may look at the medication review, but it really depends on your setting, how you want to arrange this. If we're looking at the Dutch way we do it, I try to also explain that for you may step up. So we have quite a strong primary care. So we have a sort of basic full risk assessment that is done in primary care, for example, by the GP, but also by the in many cases, it's the nurse practitioner who does it. And they do all that prompting questions and prompting tests. And if they find something, for example, possible dementia or possible underlying disease or a possible medication problem, they will scale up, and either the GP or a geriatrician or whatever they decide, whoever they decide needs to look at it, will go into that detail. But on the other hand, we also have our falls clinic, our outpatient falls clinic, and they may also refer to me or others right away, and then we'll do that full CGA for our usually frailer and multimorbid person. Usually it depends on how you organize things and who does what, but if you do it all yourself at your outpatient clinic, it may take you an hour or so to actually do that. And you may do it in different steps. You don't have to do it all at the same time, as long as, and this is something I think is really important, if you see that patient with a presentation of falls and injury, then make sure that you find possible acute urgent things before you let them go.
Could I ask one of our MUHC geriatricians to comment on what our local practice is regarding the CGA?
Jose, or who wants to take that?
I can. First, thank you, Nathalie, for such a fantastic presentation and very clinical oriented. And thank you for accepting our invitation. To answer the question, so the question is how to send someone to how to perform the comprehensive assessment. This is done in our clinic by the physician with the nurse. And you know, common problems are the falls, but as well as cognitive assessments, weight loss, weaknesses, etc. And you know, comprehensive assessment means that different domains of health is assessed, from cognition, from drugs, all the acute illness that might getting into an advanced stage that needs a comprehensive assessment to determine the impact of these diseases on the person's function capacity. This is what we do. When it's fall-related question, we tend to then refer to the falls clinic that was created more than 10 years ago now. In any event, it is part of the geriatric expertise to do this assessment with prognostication as well. I don't know if I answer you, but yeah.
Gives me a better idea. Thank you.
And the phone numbers and the faxes are the same as I posted a fax number that is a general number, but can also in that same fax number put a request for falls assessment. Thank you.
And thank you.
We're going to another, thank you, Ingrid, for the question. Dr. Doss asks about bilateral carotid stenosis and aortic stenosis. How important are these? I guess, you know, what percentage of these patients are actually falling for that reason?
Well, as I said before, in a more general sense, cardiac and cardiovascular causes for falls are common. Bilateral carotid stenosis is not a common problem, so I don't think it's a common problem if people present with falls. But of course, if you have it, it may give problems. Orthostatic stenosis for sure. Aortic stenosis is of course a common reason for syncope, but also for falls. So yes, it could in both cases be presenting symptom, but not on your top list of underlying causes. So you need to do your proper history taking and physical examination before you go further to assess this.
Thank you. There's a comment about role of proper hydration or vitamin D effect on muscles. Does that factor in?
Absolutely. What we know about vitamin D is that it is effective to prevent falls, but only if it's deficient. So we do advise to give it because in the majority of people presenting at falls clinics, it is deficient, but the alternative is that you would actually measure it and give only supplements if it's deficient. And it will act, among others, on muscle strength, as a matter of fact. Proper hydration, may affect your muscle, but may affect also your cardiovascular status and may lead to orthostatic hypotension, for example, or electrolyte disorders. So there's many reasons why poor hydration may lead to falls.
Okay. Are there any questions in the room? Okay, otherwise I'll go to Dr. Rosenblatt. Is elder abuse a common cause of falls?
Well, I think it's an important point to mention. Elder abuse is, of course, underestimated, and you may think a person has fallen while they've actually been pushed down the stairs. I don't know the actual numbers. I don't think it's big numbers, but it's something you need to keep in mind. And actually, in the Netherlands, we've installed. Well, we're on the verge of installing a similar rule. Legislation that we have for children. When children have injuries, of course, we need to check whether there might be children's abuse, and we're working on a similar thing in older adults, elderly abuse, because this appears to be a lot more common, not only when presenting with falls, than we are aware.
Just a quick question. You mentioned you have quite high numbers, over each 50% of people, 50% of people at least have one fall. When you look at those kind of falls, those numbers you quoted, are these falls with injury you're talking about, or just falls? And I'm asking that question from a cost effectiveness point of view. Should we put more resources towards this? That slide where you put numbers down, is that just falls or falls with injuries?
Yeah, so the number of falls is with or without injuries is for example for the 80 plus is 50% per year, and of those falls, about 50 to 70% have some sort of injury, including bruises and sprains and everything, and about 14% has serious injury leading to emergency department visits. So it's the actual number leading to serious injury is lower, but you should realize that there's more than the injury. There's also the concerns of falling that start occurring, the loss of functioning, disabilities that come from the falls, and the loss of quality of life, need of more help, for example, professional help. So there's this negative spiral that occurs even if there's no serious injury or a presentation at the emergency department. So still, cost effectiveness wise, it is important to also address non-injurious falls or those with non-serious injuries. And also because what I showed you is that first fall is the biggest risk factor for a second fall, and that one may be the injurious one. So you want to make sure that don't break the hip and act as soon as you can before it actually happens.
Perfect. It's 1 o'clock our time, so we will have to end the presentation. Thank you very, very much. Wonderful presentation, and congratulations on those guidelines. I think I've certainly learned a lot today. So Thanks for being here today, and thanks everyone for joining us. You're getting a lot of applause here. I don't know if you can
Thank
see that.
you.
There's
I
a lot of
do.
applause
Thank you for the
coming in online.
invitation.
So
I really
thank you
enjoyed
for
it.
joining us. Have a wonderful evening.
Thank
Bye-bye.
you. Have a good day.
Bye.
Bye.